Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today we will be discussing about a soft cataract in a young 36-year-old diabetic patient who was quite apprehensive. The pupil was mid-dilated, which posed a big challenge in these soft cataracts. Injection of phenocane, and you can see the pupil dilated enough to get a good view and easy phacoemulsification. In this case, a supracapsular phaco was planned, but the patient was so anxious that the case was started as topical but then had to be converted into a subtenon anesthesia. So by now a triplanar incision is constructed, a side port 3 clock hours away is made. The plan is to bring out this soft nucleus out of the bag and then emulsify. To do so, at least a 5.25 to 5.5 mm of rhexis should be planned. In these young patients, the capsule is elastic, so care should be taken that the rhexis doesn't run off. Staining with the trypan blue dye also ensures a bit of rigidity in these elastic capsules, and we are able to get a good 5.25 mm of rhexis. Now hydro dissection is being done and attempt to bring out the nucleus, and we are able to get a hole out of the bag. Now a bit of visco dissection is being attempted. Visco is being placed beneath the lens, and now the lens is dialed out of the bag. The soft lens is tough to get hold of, but eventually I am able to bring it out. Now the moment I put the probe in, the infusion is off, and the moment I put the infusion on, the patient gives a jerky head movement. So just shows how anxious the patient is. So I plan to switch to subtenons. The 26 gauge needle, 1 ml of lignocaine is placed in the subtenon space. After waiting for 30 seconds, the patient is quite comfortable, and we go again inside the eye with the probe with low parameters so as to avoid endothelial damage, and slowly the nucleus is being emulsified. Most of the nucleus comes out by just vacuum. Minimal amount of phaco energy is needed to emulsify this soft nucleus. Slowly we are eating away the nucleus. Care should be taken to avoid any endothelial damage. A good OVD should be used to protect the endothelium, and as we are using minimal amount of phaco energy, so risks to the endothelium is less, and in no time we are able to emulsify the complete nucleus. The attempt was to stay as close to the iris plane as possible And that's it. Now the cortical wash is being attempted, but as you say, a case is not over until it's actually over. So what happens while I'm doing the hydrodissection, we'll see in a while. For now, with a 23 gauge cannula, the cortex is being removed. The subincisional cortex should be removed by going from the side port. This deepens the chamber and gives better access to the subincisional cortex. And we have a clean bag. And now is the time to inject the IOL. Wound assisted implantation of hydrophobic intraocular lens is done. The leading haptic goes in the bag. And the trailing haptic is then gently dialed in. So after the subtenons block, the patient was very comfortable and cooperative. So one should adjust and should be very flexible while doing a surgery, and should be ready for plan B. So in this case, I was ready to do a topical phaco, but then when I saw that the patient was not very comfortable, I switched to subtenons anesthesia, and I was able to complete the case easily. And now, as I am hydrating the wounds, you can see there is IOL capture. The iris has gone behind the 6 o'clock part of the IOL. So if I leave it here, it's a cause of concern. So just go through the side port, deepen the chamber, push the IOL back, and we've got a good round pupil. The IOL is in the bag, and this young patient was unable to drive, was having a great deal of photophobia. Night driving was a problem, daily activities was a problem, is now a happy patient. I hope you like this video. Thank you for watching.